Yes, ma'am. We are live now.
Yeah, Dr. Sanket. Yeah.
Thank you. So good evening, everyone. I, Dr. Sanket Nevale, representing Medical Affairs at Wockhardt Pharmaceuticals. I am glad and I'm happy to have all of you together over here. We have an eminent faculties all over the country who has joined in today. We have met on this platform called as L20 Summit, where we're talking about the time-tested legends and the new kids on the block in the management of type 2 diabetes. We are celebrating more than 20 years of two brands, that's Vosulin, that is a human insulin, and Glimaday, which is Glimepiride, of Wockhardt. We also have seen the newly or the indigenously developed, after approximately 15 years of research, that we have the new molecule, the new antibiotic on the block, which is Emroc or levonarifloxacin, developed by Wockhardt. So all of this today, we would be having a scientific feast with eminent KOLs from the country. And today we have been joined with more than 4,000 registrations and more than hundreds watching us live. Our faculties today are Dr. N.S. Verma, Dr. Snehal Tanna, Dr. L. Srinivas Murthy, Dr. Rahul Sharma, who would be delivering the talks with the chairmanship of Dr. Verma. I'm expecting that in this meeting today, we'll be having a scientific feast with a development of newer thoughts in the management of diabetes and with a covering of an antibiotic, which is Emroc. The agenda of the meeting goes on a very smooth. I will have Dr. Alpa Singh from Wockhardt Medical, who would be doing the welcome and introductions, followed by Dr. Verma, who is our chairman, who would be doing our overview of the discussion and context setting. Then we'll have Dr. Tanna, who would be speaking on human insulin and SUs. And then we'll have Dr. L. Srinivas Murthy talking on SGLT2 in combination with DPP4 inhibitors and its place in therapy. Then we'll have a session on MROC by Dr. Rahul Sharma, followed by Q&A and closure. With that note, now I'll hand it over to Dr. Alpa Singh for the introductions. Over to you.
Thank you, sir. Thank you so much. It's my privilege to welcome everyone again. And my privilege to welcome our chairperson for this today's session, that is Dr. N.S. Verma, sir. So give me a minute, I will share my screen first. I hope everybody is able to see my screen. So our chairperson for today's event is Dr. N.S. Verma, sir. He is a professor and head of Department of Physiology and officiating head of the Department of Family Medicine, KGMU of Lucknow. His area of interest is chronobiology and metabolic diseases. He has 230 original publications in the peer-reviewed index journals. He has been awarded with 14 international and 38 national awards in the field of cardiovascular and the metabolic research. He is a life member of 14 international and 29 national scientific bodies. He is holding many positions in various scientific bodies, like he's been the president of Association of Physiologists of India. He's been immediate past president of UP Diabetes Association. He's been president of Asia Pacific Society of Hypertension. He's also the president of International Society of Medical Nutrition, a secretary of General Indian Society of Chronomedicine and ACP India chapter. He's been a treasurer of Indian Society of Hypertension and UP chapter of RSSDI and director of South Asia Affairs of World Hypertension League. I would like Dr. N.S. Verma to chair the session and give the overview of the today's discussion. I'll just stop this. Stop. Yeah.
So Dr. Alpa, would you like to continue with the introductions or you want to hand it over to Dr. Verma for his context setting?
So Dr. Verma can do the context setting. We can go forward with each and everybody's introduction when their session will start.
Before the session. Perfect. Yeah, so Dr. Verma, over to you, sir.
Thank you. Thank you for organizing this very important meeting.
I welcome you all in this evening. And today, as discussed by Dr. Sanket, we are here to discuss few very important points regarding the diabetes and also antibiotics. Both these areas are very important. You all will agree that diabetes from last 100 years, we were having only one drug 100 years before, that was the insulin. And today we have more than 20 drugs to treat diabetes. Still, diabetes is increasing. So where we are missing, how beautifully we can utilize all our armamentarium and how beautifully we can slow down the progression of disease. This all is an art, and that art can only be learned by the legends which we have today in our kitty. And definitely, I think very soon you will listen all of them, and they will discuss that how beautifully you can choose your patients for insulin, who they require insulin, and other patients who require OHAs. And in OHAs, what OHAs at what place? So all these are agenda of today's meeting. And definitely today, it is the time of the precision medicine, and every patient require different set of drugs. We have more drugs in our kitty. Now we can choose the drugs according to our patient. And before 20 years before, there were hardly any drugs. So we were bound to give same drug to everybody. So today we have a lot of insulins. We have sulfonylurea. And you will agree that still sulfonylurea have a place. And we cannot say that the newer drugs only can manage the diabetes. Similarly, we have SGLT2 inhibitors, gliptins, a lot of things in our kitty, and how they will be used. This will be taught by our legends. And we will also discuss one of the very important agenda today, that is regarding antibiotics. Two drugs in India have been misused a lot. That is the PPI and antibiotics. They are misused, and because of that, a lot of bacterial resistance is coming. And in most of the viral infections, a lot of antibiotics are given, which is not correct. And today, I'm glad to know that one new antibiotic developed by the WOCAD will be talked about, and we are eager to listen about that also. So this is regarding the today's meeting. I think first we are going to talk about the human insulin and sulfonylurea. For that, I will like to invite our speaker of the day, Snehal R. Tanna, and his introductory slide, if you have it.
Yes.
I'm meeting first time to Dr. Snehal, but today I'm fortunate that I will listen to him. Dr. Snehal Tanna is a diabetologist at Jupiter Hospital. His MBBS diploma in diabetology, postgraduate course in diabetic foot, FRCP London, practicing diabetology since 2000, and assistant lecturer in medicine at MUHS, postgraduate teacher for diploma diabetology since 13 years, and course director for Jupiter GE Diabetes Educator course, which is HSSC Healthcare Sector Skill Council recognized. So with very brief introduction about Dr. Snehal Tanna, I welcome him, and please go ahead with your talk. And at the last, we will discuss and the question and answer session. So Dr. Snehal Tanna, now this.
Thank you. Thank you, Dr. Verma, for the kind introduction. And it's really a privilege to be over here with you on this virtual platform. So I thank WOCAD for the same. Good evening, everyone who's around here and who's on the audience side and on the panelists as well. My topic today is actually quite simple. We all just hold on, yeah. Yeah, okay. You can see my slides, right? It's my slides are visible, right? Yeah, okay, thank you. So my talk today is quite simple and straightforward. In a sense, why do I say that? Because we all have been using these two particular agents, sulfonylureas and human insulins, per se, human insulins, for a long duration of time. All my respected co-panelists today and co-speakers today have been prolific in their practice in terms of, and while we were studying as well, we have been using these drugs since that time. not much has changed. Yes, Dr. Murthy will discuss about the newer drugs, newer kids on the block, and it has definitely changed the way we see our diabetic patients and how we manage them. But saying that, old is still gold, and there are few scenarios, many scenarios in fact, where your human insulins and sulfonylurea do it. They are time-tested legends and do provide a major contribution to the management of diabetes. Just an overview about the global prevalence that has been increasing over a period of time. As you can see, the increase percentage from 21 to 45 expected increase. Current trends, if the current trends continue, 783 million adults will have diabetes by the end of 2045. In India, 1 in 7 adult is living with diabetes. 74.2 million adults with diabetes are present in India as of now, and it's projected to be almost double, 124.9 million by 2045. And the prevalence of people with diabetes is around 9.6%. So, two things. We've been managing diabetes for long duration of time. I mean, all of us and our predecessors, our teachers, we did not have a lot of option in the past, and now we do have a lot of options, but still glycemic control remains elusive. You know, the metformin or the reduction of insulin resistance by metformin is a beneficial factor in almost all the Indians that present with uncontrolled glucose or with dysglycemia in our clinics. But you do require other means and other modes of for management of diabetes. You need to target not just insulin resistance, but also need to push pancreas to produce more insulin with sulfonylurea, and if needed, we do require many times insulin as well. Dr. Murthy will cover in detail the DPP-4 and SGLT2 combination that has come up, and there are benefits and there are kind of scenarios where they work much better than the sulfonylureas. But there are also pros and cons about it as well. 34% of an annual income of an adult type 2 diabetic patient goes for diabetes management, is what is seen from this study from India. So the cost that a diabetic patient incurs for management of only one particular disease, though it's a conglomerate of all metabolic syndrome, I agree, and diabetes alone cannot be segregated from the rest. But 34% of an income is spent in not just managing, but also, I mean, over a long duration of time. This particular cost keeps on increasing. Two drugs that I'm going to speak today are sulfonylureas and insulin. Sulfonylureas were discovered in 1942, available since 1960. They are definitely efficacious in terms of getting down your patient's HbA1c, and they do have, the newer sulfonylureas do have better safety, and a wide range of patients can be put on the same. Insulin has been here for more than 100 years now, 101 years to be perfect. And there are newer insulins that are available, but they are costly. Let's start with sulfonylureas. No one would argue on the fact that sulfonylureas are good and they are the drugs of choice if you have to get your patient's glucose under control on some oral tablets. Amongst all the oral tablets that are available, the groups of oral tablets that are available, sulfonylurea are the only ones that are kind of I should say the drugs that comes in time of crisis, where you want your patient's glucose to be controlled fast. There are lots and lots of trials, and there are lots of patients in real world evidences from your and my clinic who will vouch for the fact that, and you and I will kind of ascertain the same, that sulfonylureas did get these patients' glucose under control. A systemic review and a meta-analysis of efficacy of sulfonylurea as a monotherapy as compared to placebo has definitely shown that it is beneficial in getting your patients HbA1c. Despite all these factors, they still remain underutilized, though we do consider cost as one of the key factors while deciding what drug to be introduced in our patients. Long-term efficacy, again, the mean duration of 14 years did show that sulfonylureas could be effective and safe over a long period of time. You would have anecdotal patients who will tell you that they are on glimepiride per se for ages together, for years together, and they are still very well controlled. In the same way, there are few of them who are on glimepiride, but there's newer drugs that are there in the market now, like glimepiride and gliclazide, do appear to give good amount of control and are durable as well. They do help in managing your macrovascular complications. Most of the benefits come due to the glucose control that it offers, but it is also shown that the newer sulfonylureas are cardiovascular safe and do not cause any problems in terms of cardiovascular mortality as well. Safety of sulfonylureas have been compared to standard drugs like DPP-4 inhibitors, one of them being linagliptin, which was seen in Carolina's trial, which showed that there was no difference between the cardiovascular risk that glimepiride would pertain on your diabetic patients as compared to a linagliptin, which is considered to be one of the safest DPP-4 inhibitors in the market. Again, if you consider studies which were way too older ones like UKPDS, even in them, sulfonylureas were used and they were compared with placebos, they were compared with, in fact, metformin as well. And basically, sulfonylureas have stood time in UKPDS trial, in advanced trial and accord trial where gliclazide was used, modified release gliclazide was used, did show beneficial effects of gliclazide, that's sulfonylurea, in terms of vascular disease and cardiovascular outcomes as well. And there was no increased cardiovascular risk which was reported by any investigators. Sulfonylurea do not increase any risk of all-cause mortality, which was seen from this meta-analysis, which covered 47 randomized controlled trial, which included 37,000 or more than 37,000 patients. And they were not they did concur that the sulfonylureas were not associated with increased cardiovascular mortality. The newer sulfonylureas are definitely safe. The glimepiride, gliclazide are definitely safer as compared to glibenclamide, which was the previous sulfonylurea, or the so-called second generation sulfonylureas. They are also, because of the unique mode of action and the sulfonylurea receptor attachments, gliclazide and glimepiride do have benefits over the older sulfonylureas. The risk of overall mortality in patients with type 2 diabetes receiving glipizide, glyburide, or glimepiride therapy did show that glimepiride may be the preferred sulfonylurea over glimepiride and glibenclamide, or it's also called as glyburide, and it has a lowest 3-year mortality amongst all the sulfonylureas. Sulfonylureas have significant lower risk of hypoglycemia. The newer sulfonylureas that are used in and nowadays used in our market, like your glimepiride and gliclazide, do have least risk of hypoglycemia when compared to the previous sulfonylureas. There are guideline statements on affordability and accessibility of type 2 diabetes treatment as issued by the National Institute for Health and Care Excellence in UK. They do mention that when cost effectiveness is a major concern while managing your diabetic patient, sulfonylurea should be used over, or should be preferred over other oral drugs. The newer drugs guideline statements on, again, affordability and accessibility by WHO does mention that give a sulfonylurea to a patient with type 2 diabetes who do not achieve glycemic control with metformin alone, or who has who is contraindicated for metformin. ADA statement also amongst the chart that you see, the last one where consideration of cost and accessibility is involved, sulfonylurea scores over the rest of your newer drugs that are available. Though luckily in India, we are quite lucky to have a lot of other options in our market, as Dr. Verma just mentioned. But there are places where sulfonylurea accessibility and affordability do play a major role in deciding which drug to be used first. Again, South Asian consensus do mention sulfonylurea could be an oral glucose lowering agent of choice where low income group settings are there. Human insulin, just giving few slides on the human insulins, which is another time tested molecule. We all are aware of the pathophysiology of type 2 diabetes, where at the time of diagnosis, almost 50% of the beta cell are exhausted. They do require some amount of rest so as to work for a long duration of time. They do use of insulin way too early in the management of diabetes do help reduce the legacy effect that that is seen because of the glucotoxicity in our patients. Almost 5.6 million Indians are using insulin in India, and it's basically it's basically human insulins what we have used in the past and are still available are more affordable as compared to the newer insulins that are there in the market. Many patients skip their insulin doses and underuse the insulin that is advised to them because of the cost factor. 25% of the patient with diabetes confessed about the cost-related underuse of insulin. 66% of these individuals faced hardship in purchasing diabetes equipment that are required. It's not only the insulin and the syringes that incur the cost, but also the monitoring that should be considered while advising a patient on insulin. Patients skip insulin doses due to high cost, as was studied in this publication in JAMA in December 2018. 1 in 4 insulin treated patients cut back on insulin use because of the cost. And there is the skimming of insulin is 3 times more likely to have obviously a poor control. WHO do mention the fact that insulin should be available at all times at a price that the individual and the community can afford. So similar sentiments are presented by American Diabetes Association, where providers should prescribe a lowest price insulin is what the guidelines mention, required to effectively and safely achieve treatment goals. And providers should be aware of the rising cost of insulin preparations, which we see in the market with the newer insulin coming in the foray. And when you switch a patient from an affordable insulin to these costly insulin, there are risk of non-adherence for the same management. As far as addressing the cost issue is concerned, an Endocrine Society position statement to mention that everyone involved, right from the supply chain, in the supply chain of insulin as a molecule, have to kind of pitch in different ways so as to kind of have a good amount of affordability issue as far as insulin goes. Well, this is something which is a dream come true, and it is true for a lot of different pharmacological drugs as well. As far as comparing your human insulin vis-a-vis the analogs, as we know that the basal insulin which we have used and have learned is the NPH insulin. You have newer analogs like larger degludec, detemir. You have, as far as prandial insulin goes, which your Vocilin R, which is regularly been used over a long period of time, do have analogs like lispro, aspart, and glulysin. And in a similar way, there is a mixture or a premix insulin like as against Vocilin 3070 and 5050. You have no mixes and analogs. So aspart plus degludec, aspart plus lispro plus protagonized lispro. So my point is, you will have options in your patients, but you need to choose the most affordable insulin. When you do that, are you compromising on their efficacy? Not so much. Lots of studies have shown that there are benefits with the newer analogs, but it is not that significant that you have to shift all your patients who are on human insulins to the analogs one. There are specific indications, there are specific group of drugs that do require newer insulins owing to their ultra short and ultra long duration, but more or less the efficacy wise, they do not give more. I'm pretty sure we all have tried and we all have compared in our individual clinics and do not give so much of a benefit so as to give all our patients who are on human insulin shifted to the analogs. As far as basal insulin versus their analogs are compared, yes, there is reduced risk of hypoglycemia. They work for a longer duration of time than the NPH, but the overall reduction of HbA1c or the reduction of fasting glucose levels and later on postprandial glucose levels can be achieved with human insulin as well. Safety wise, yes, the newer insulins, basal insulins, do have reduced risk of hypoglycemia as compared to the human NPH insulin that we have used. And hence, there are specific group of patients that do require analogs, but more or less as a general population, you could use NPH in most of your patients. Again, as far as safety goes, not major different. There is very little benefit that is seen from the analogs, that basal analogs that are available in the market versus the NPH insulin. In practice, the effects of NPH versus basal insulin as far as safety goes can be modest, is just modest, and it is there. I mean, I'm not denying the fact that it is not there, but it is modest and not that significant so as to give everyone their newer dose. So where cost is involved, where so you need to decide between an increased number of episodes of nocturnal hypoglycemia and the risk for individual patient versus the cost factor over a long duration of time that the patient has to continue taking insulin. You have to balance between the two for each on every patient who is on insulin who comes to your clinic, and then decide whether you want to give the benefits of cost versus the increased probable risk of nocturnal hypoglycemia. If you see the prandial insulins, again, the meta-analysis show that no significant differences were seen in the serum HbA1c concentration, though the postprandial peaks are better controlled with the newer analogs. As far as efficacy goes, rapid-acting insulin analogs offer little benefit relative to the conventional human insulins in terms of glycemic control. As far as safety goes, again, there is little benefit over and above in terms of obviously hypoglycemia, both overall and nocturnal hypoglycemia. The risks have reduced, but if you see the efficacy wise, the HbA1c reduction is almost same in both the group of whether you use human insulin versus your analogs. Same thing goes for your premix insulin, where reasonable options should be provided to your patient who needs premix insulin in terms of affordability, if you know that your patient is going to take insulin for a long duration of time. Newer injectable therapy like GLP-1 receptor agonist, which is now also available in the oral therapy or oral form, have kind of changed the scenario of management in the management of type 2 diabetes, which do target multiple comorbidities, including obesity. And it is probably going to kind of be a co-therapy for patients who are on insulin, or probably sulfonylureas, or probably can be added with SGLT2 inhibitors. But saying that, as of now, because of the cost factor, they still appear to be a bit for not for everyone therapy, though there are benefits of using this particular therapy, especially in patients who are at risk of cardiovascular complications. So saying that, if you're thinking of cost factors and you're thinking of beneficial effects in terms of HbA1c control, you can still use the older human insulins and the sulfonylureas as well. Human insulin are definitely economical versus their analogs, as is seen from this comparative study as far as the cost go. To summarize, cost of diabetes is increasing. Sulfonylurea represents an accessible and affordable treatment option. Many patients with type 2 diabetes eventually require benefits of insulin. Advantages of newer analogs in terms of reduced risk of hypo and reduced postprandial peak are there, but the absolute HbA1c reduction is almost similar as compared to the human insulins as well. For many patients with type 2 diabetes, human insulins may be an appropriate choice of therapy, and it's not that all patients require analogs. Achieving the best balance between efficacy and affordability, along with reduction in the hypoglycemia and trying to manage other comorbid condition, appears to be the need of time for effective diabetes management. So thank you all of you for the patient hearing. I think, no, I didn't shoot a lot of my time. I think I have 3 or 4 minutes extra. Sorry.
Thank you, Dr. Snehal, for very excellent talk. I think we will take questions at the end of finishing both diabetes.
Sure, sir.
So I think next talk will be by Professor L.S. Srinivasan Murthy, and I think he's well known, but still I request his CV slide. I know him very well. I can tell about him without slide, but since the slide is here, I would like to have it. So Professor Murthy is a MD FRCP and FRCP from all the 3 places, and FACP, FICP, FFR, RSSDI, fellow of RSSDI, and also senior consultant physician and diabetologist at Life Care Hospital and Research Center at Bengaluru, and a former consultant at Fortis Hospital, Glengals Global and Apollo Hospitals. Faced successful US FDA inspection in the field of research. He's a man of research, and FDA research is of different quality, and he has faced that. And world's first ever Canadian inspection outside Canada successfully. Principal investigator over 85 multinational clinical trials. National lead investigator for India in multinational phase 3 study, and received Inspiring Diabetologist of India 2022 award from Economic Times. Received Indian Academy of Diabetes 2023 award for outstanding community service. Still 2023 is left. He will definitely bag more awards in the coming time. Delivered prestigious R.J. Wegman Oration at BP Khan 2022 at Lucknow. Delivered prestigious Y. Subbarao Memorial Oration 2022 at IMA. Has national and international publications, deliberation to his credit, faculty at various national, international conferences, and vice president of National RSSDI, governing council member of ACP India chapter, vice chairman of API Karnataka, governing council member of KRSSDI, CCS DSI, Indian Society of Chronomedicine, and Indian Society of Hypertension. And is also organizing secretary of ACP India National Conference held in 2021 Goa and 2022 Vizag, consequently, and Organizing Secretary of the coming BP Khan 2022 at Delhi. So this is a brief introduction of Dr. L. Srinivas Murthy, and he will be talking more about the SGL2 and gliptins, the drugs, how beautifully they can be utilized in the slowing down the progression of diabetes. Over to Dr. Murthy.
Thank you, sir, for that very kind introduction. Always enjoy Verma sir's company, and it's a learning experience every time we encounter. And let's move on to the presentation today. So my slides are visible, right?
Yes, sir, it is visible.
Sorry, I think it has gone far ahead. Yeah. So clinical approach to combination use of SGLT2 inhibitors plus DPP4s. I'm sure this August gathering will be using these molecules combinations. I'm sure already, and this is not a new baby, it's already grown up now. And that the evidence for this rational combination, because in India, we know the irrational combinations and what the mocking we get from the West because of irrational combinations, all of us have gone through. But this is something, today we are going to talk about the scientific evidence of this combination and where do we place in our treatment armamentarium in management of diabetes. As you saw, the previous talk about SUs, where they have clearly the guidelines are bifurcated for want of economic reasons that SU can be used. Now, but luckily in our country now, the SGLT2, especially the DAPA, has become so affordable that literally every other patient can be utilized this. And of course, DPP4s have been there for more than 15 years. I've done one of my first few clinical trials and was with the sitagliptin way back in 2006 and 7. And it has been sustaining in the market. And that itself is a time testing molecule, which is there, the DPP4s and SGLT2, of course, are the game changers in the management of diabetes. So let us look at the evidences. And before we proceed, just look at the basics about the prevalence. Dr. Snail has already told about these prevalences. And India, we have a prevalence of about 9.6%. Literally 1 in 7 all adults living with diabetes worldwide exists in India. So apart from economic progression, what we're seeing this also where we are raising, and this is a matter of a concern, not a matter of pride, unlike other achievements what our country is doing of late. And we have a typical thin fat phenotype, sorry, where it is associated with the various unique features like early age of onset, early age of complications, early decline in beta cell, higher insulin resistance, higher intake of carbohydrates and thus postprandial hyperglycemia, physical inactivity, central obesity, unique dyslipidemia, of course, early CV disease presentation, and of course, the NASH association also is more in our country. So this makes us very unique population when compared to the Western diabetics. And this is a very depressing slide where it shows the current status of diabetes management in our country. Up to 70% of them do not achieve the target level of A1C, in spite of all these molecules which are available in our armamentarium. So essentially, non-compliance with lifestyle measures and multiple other factors are responsible for this non-attainment of glycemic control in our country. Of course, this is true in the Western countries also. And just to tell you a data that the GLPs and SGLT2s in a country like USA are only 5 to 6% of prescriptions have gone up beyond after this evidence of various trials also. That's the status there also, but it is very depressing to see 70% of them in our country are not achieving the target. And the onus clearly lies on us as treating physicians, clinicians, that we are not managing their sugars in spite of available advanced treatment options. Now, why we should look at the target? Obviously, we are always quoting these UKPDS, though it's about 30 years now. The good glycemic are the legacy effect, where just 1% reduction can bring down 24% reduction in the microvascular disease, 15% in the macro, and 13% in all-cause mortality reduction. Of course, ACCORD, ADVANCE, and VADT clearly showed that early intensive glycemic control improves the microvascular outcomes. So despite this intensive glycemic control, the residual CV risk has remained a significant unmet need in this diabetic population. And these drugs, the GLP-1s and the SGLT2, have clearly changed the approach to management of diabetes in our practice, and they have clearly shown the CV outcomes regardless of the glycemic control. That means even in non-diabetics, we are showing the evidence now, and they have become very, very essential part of armamentarium for appropriate cardiometabolic risk management in all diabetics. I mean, the evidence is so growing, so robust that literally, if we do not initiate any patient on SGLT2 or DPP4, it looks like a crime now. That is the extent of data which is generated literally every day. So with increased availability of these choices, which can address the various unmet needs, the question of rational combination in diabetics holds deeper and broader implications. As I said, we have all kinds of irrational combinations. So to counter this unmet need in the management of diabetes, especially in Indian context, we need a combination approach, definitely to reduce the glycemia, need additional treatments which can provide both glycemic and extra glycemic or pleiotropic benefits, and which can reduce the occurrence of hypoglycemia or weight gain. Again, truncal obesity is a big challenge in our country, and distressing side effects of traditional antidiabetics like hypoglycemias or other heart failures with the pioglitazone, etc., are to be countered. And it has to be an oral option, because whenever you say injection, the GLP-1s are great drugs, but the only drawback, like insulin, is the insulin injection phobia. And thus, we require a oral treatment option which can patch up this unmet need. And this is what I was quoting in my opening remark, that the Indian market is overwhelmed with the FDCs. 50 such FDCs are seen with more than 500 brand names. Can you believe that? And DCGI has recently banned 344, that means 75% of these FDCs lack therapeutic justification. Just like that, the permutation combinations were fixed and they're manufacturing it. And the rational and synergistic FDC of these anti-diabetic drugs may be considered as a prudent option to reduce the pill burden and thus compliance, because that's the biggest problem. In a study, it is clearly shown after the 3 drugs, that is 3 individual drugs, if you add on a 4th drug, the compliance can drop as low as 70%. And that's very, very significant. So this rational combination will help our patients to achieve the A1C faster than any monotherapy. So let us look at the meeting the unmet need in the form of rational combination of SGLT2 and DPP4. This combination, we know that treat to target benefit to the patient after metformin initiation or even prior to metformin initiation in suitable patients. This is what the guidelines have gone up for the first time, that even ahead of metformin, you can initiate these drugs, class of drugs. That's the robust evidence which I was talking about. And of course, in patients where A1C is not well controlled on metformin, this is in general the indications after metformin, and people who are not on metformin with a suitable patient, which I'll be talking in a couple of slides later, in patients with uncontrolled A1C who are all metformin failures. Now, before we start the combination, let's look at the DPP4, their mechanism of action in Indian diabetic patients. Indians are supposed to be having increased DPP4 enzyme activity, and thus DPP4s better perform in the Asian Indian. That's the left side. I'm showing the article which defends this, that the high circulating plasma DPP4s in non-obese Asian Indians in diabetes correlates with the fasting insulin and LDL-C level. This is a publication in VMJ and Dr. Anup Mishra. Reduction in A1C was achieved in the Asian with DPP4s irrespective of age, BMI, and renal function. That's very, very important, because this point you can see in the bottom, this is what we see in routine clinical practice. So it can affect the A1C in a positive way, irrespective of the age, body mass index, and renal function. And remember, DPP4s definitely work better in Asian patients. Another evidence to show that the SGLT2 also works, of course, not to the extent of DPP4s, but the efficacy is better in Asian ethnicity compared to the GLP-1s. Hence, combination of SGLT2 DPP4 will be suitable in Indian context, which will be safer, rapid and sustained glycemic control can be achieved, improves both insulin resistance and beta cell function because of the different mechanism of action, helps to reduce the body weight and blood pressure, which is the pleiotropic benefits of this combination. more than anything, it reduces the pill burden. And of course, in Indian context, overall, it is a cost-effective combination now, thanks to all the pharma friends who brought down the DAPA to the pricing of almost like a metformin or any antihypertensive drug. So this is what I was talking about, the complementary mechanism of action between these. This is what the synergism we expect whenever there is a FDC, that is a fixed drug combinations. We have SGLT2s acting on the kidneys mainly with reducing the glucotoxicity and thus producing all the pleiotropic benefits. Whereas you can see the DPP4s works on the pancreas at the level of intestine also, producing this incretin effect where it increases the production of GLP and GIP both. And of course, they are weight neutral, but that is taken care by your SGLT2, and thus the overall reduction in the hypoglycemia and pleiotropic benefits are seen when you combine these rational drugs, the SGLT2 and the DPP4 class. Thus, it will take care both the prandial and the fasting sugars, low risk of hypoglycemia with insulin dose requirements will be less, and of course, hypoglycemias are very, very less in both these combinations. Now, the Omnius octet, we know the famous Diffranzo Omnius octet. It will literally take care 5 out of these 8 Omnius octates, pathophysiology. That means we are hitting the root cause of basic pathophysiological defects with respect to this combination. And of course, if you add on metformin, it will literally cover everything. I mean, all the basic defects in the Omnius octate. And of course, GLP-1s are the other class which usually counters. So pharmacokinetics, that is what we are talking about, synergism. You look at the bioavailability, the half-life, once a day dosing, high affinity binding to the target DPP4 or SGLT2, and inhibition has to be more than 80% minimum to call it viable, and it is 80% and 95% with respect to the SGLT2 and DPP4s. So this similar PK profile makes them compatible, makes them work better with a good synergism. So always whenever a new combination, new fixed drug combinations comes up, we look for evidence. So evidence clearly suggests that the FDC of SGLT2 DPP4s are effective and safe in controlling the glycemic parameters. So initial combination in a drug-naive patient in diabetics as an add-on to metformin monotherapy, we have evidence. So look at this FDC evidences with respect to the A1C reduction when it is less than 8.5% and A1C reduction when it is more than 8.5%. Obviously, when it is more A1C, that is more than 8.5%, the reduction is more pronounced with respect to the combinations. Here you're seeing the 10 mg and 5 mg of DPP4s, that is Lina and Saxa, and the DPP4 like sitagliptin, which is 100 mg. So the reduction was observed significant, which is statistically significant number from baseline in drug-naive diabetic patients. These are all drug-naive patients. Now let us look at the patients who are on monotherapy with metformin as an add-on to metformin. Again, look at the reductions, which are all significant, and these are all the trials available results. And of course, results for less than 8.5 in these two groups are not there, but for A1C reduction in the group, more than 8.5% are clearly visible, as you can see here. Now, the clinical evidence, there are various studies to show the Empalina, the metformin add-on, the DAPA, SITA, all these trials have clearly shown that there is a pleiotropic benefits apart from reduction in the A1C. And whenever after the efficacy, we talk always about the safety whenever a new molecule or a new FDCs come. So the overall safety profile of these FDCs was similar to those of individual components. There was no significant differences with respect to the hypoglycemia, the UTIs, and event-related hypovolemia and ketoacidosis. This is what we always get worried about, especially the UTIs and the GTIs with respect to the SGLT2. Now, combination drug surprisingly causes lower rates of genitourinary or the UTIs when you combine SGLT2, when you do not combine SGLT2 with the DPP4. Supposed to be, the mechanism of action is supposed to be the DPP4 inhibitors inhibit the enzymes in this bacteria or microbes, and thus will make them inactive, and thus there is a reduced reduction of GTIs. So it is worthwhile to counter, because this is something troublesome in few of the patients where recurrent UTIs, recurrent GTIs, where you have to withdraw SGLT2. So if you combine rationally with the DPP4s, definitely you will help our patients also to retain, and these dropouts will be very, very minimal in this segment. And of course, now coming to the CV and renal outcomes, and that is where these molecules changed the approach of our management, and all the bodies have to change their approach and classification and the guidelines. So SGLT2 in the FDC reduces the heart failure and worsening nephropathy in diabetic patients with CV disease. DPP4s have got an established safety in CVOTs, but though none of the DPP4 trials have shown the beneficial effects, they've been CV neutral in general. But look at the SGLT2s, they've got enough robust evidence with respect to the heart failure, CV death, 3-point MACE, or renal outcomes. Now, this is what the guidelines I was talking about. They literally changed after the discovery of these molecules and the various clinical trials which were published after metformin. If somebody has got an established ASCVD or indications of a high risk with respect to their age above 55 years, and you can see here the other risk factors which include obesity, hypertension, smoking, dyslipidemia, or albuminuria, you need to initiate this as a primary prevention. And that's something which all of us should practice in our routine clinical practice, that the primary prevention part to our patients, we should give these molecules in the right time so that the complications are prevented. And of course, heart failure, CKD, you can see this classification. And patients on metformin with lifestyle modification without indicators of high-risk CVD, ACVD, CKD, or heart failure, DPP4 and SGLT2 can be easily used as alternative to the management of diabetes when it comes to the primary prevention angle. Now, what does the guideline suggest? As I showed you in the previous slide, they clearly say the patients with established ACVD are high-risk patients, that is, such as more than 55 years, with coronary, carotid, or lower extremity artery stenosis more than 50%, or LVH evidence, or heart failure, or CKD, an SGLT2 inhibitor, or a GLP-1 with demonstrated CV benefit is recommended as part of the glucose lowering regimen, independent of A1C, independent of metformin use. Please underline the last two lines, independent of A1C, independent of metformin, you will still find the benefits. Even now, this statement will extend to non-diabetics also, like in DAPA-CKD, what we saw, even in non-diabetics, it is shown the reduction in the heart failure. Just to show you one of the evidences, HbA1c more than 7, less than 10, it was randomized to DAPA 10 mg plus sitagliptin plus metformin, another arm, placebo, sita, and metformin. So primary endpoint, to look at the change in the A1c in 6 months period. Secondary endpoint, change in body weight. Inclusion criteria, more than 18 years, who are on DPP4 treatment naive and add an A1c of 7.7 to 10.5, or who are on DPP treated with an A1c between 7 and 10. Of course, BP has to be less than 160/100 at randomization. Study dosing, eligible patients were stratified based on the presence or absence of background metformin, and with each stratum were randomized to either DAPA 10 mg plus sita or placebo plus sita. Look at the results, reduction in A1c, very glaring. You can see the difference with sita and metformin. When you add on DAPA, look at the results on the left side. Similarly, look at the weight loss when you have DAPA, sita, and metformin versus sita and metformin. Of course, metformin is a wonderful drug. Please keep it, though the guidelines say you can start this combination ahead of this. I would personally feel metformin has to be there for all our Indian patients, except for compelling contraindications. Just to show you, sitagliptin is one of the tried and tested DPP4 so far compared to other gliptins. You can see this was the first US FDA approved DPP4. As I said, this was one of the first clinical trials which I did way back in 2005-06, and maximum publications approved in all major markets, maximum ongoing trials, largest CV OTT cause was with 14,000 plus patients. Of course, Lina is another wonderful molecule, which CV OTT trial like Carolina was there. Bilda, though it is studied well, approachable, not approved in US market for various reasons, ongoing trials, but no CV OTT trial, and it's a BD dosage, which makes it not very, very viable to market with your DAPA. Let us look at some specialties of DAPA. It is only SGLT2 approved to help delay the worsening of CKD in patients with risk of progression with or without type 2 diabetes. This is what I was talking about earlier, DAPA CKD. And that was the first trial which showed that the reduction of heart failure with the background of CKD. Even patients with CKD, the patients had a benefit of heart failure reduction, unlike contrary to the belief that the DAPA or the SGLT2s do not work when the EGFR falls. And DAPA CKD clearly showed that. It is the only SGLT2 which significantly reduce the risk of individual components of CV death and hospitalization for heart failure in patients with reduced ejection fraction. And this was done way back in Declare-TIMI after the EMPA. The FDA instructed the DAPA to include the heart failure hospitalization as one of the primary endpoints. That was the first trial where the FDA changed the protocol. DAPA is the first line GDMT, that is the guideline recommended treatment with class 1A recommendation for heart failure with reduced ejection fraction in AHA, ECC, HFSA guidelines for the management of heart failure. Now we know there are 4 pillars for management of heart failure: beta blockers, MRSA, the ARNI, and DAPA are the 4 pillars which we literally have to use it for all these patients. DAPA heart failure study is the largest landmark SGLT2 study to date for patients with a reduced ejection fraction with about 5,000 patients. DAPA is the only SGLT2 with a CVOT and a major primary prevention patient publication. That is something you should remember. Dosage 100 plus 10 mg, 1 tablet. Convenience, compliance, this is where you need to look at, and you can initiate this drug whenever AGFR is more than 45. Now let us look at where do you place this FDCs in our routine clinical practice. Initiate with lifestyle modification in treatment-naive patients when metformin is contraindicated, intolerant, or A1C is more than 8%. Straight away, you can go to this FDC. Again, in treatment-naive with metformin patients when A1C is more than 9%. Uncontrolled on metformin, you can again go ahead. Uncontrolled metformin, second line, again, you can go on metformin plus DPP4 as SGLT2. Uncontrolled on metformin, second line, except DPP4 as SGLT2, you can add on this. So literally you can see even if insulin plus or minus other agents, you can use this combination. So they've got placement in the drug naive, they have monotherapy failure, dual therapy with insulin. So what else you require? That this combination can be preferred over other conventional therapies for the benefits which they're showing apart from the cost benefits in Indian context, CV benefits, heart failure, CKD, literally, I mean, the patients are complete protection. I would say the holistic approach would be metformin, SGLT2 and DPP4s. The patients will be protected, or at least we can impart or postpone the complications. Whenever, of course, the HbA1c criteria is applicable, then SGLT2 inhibitors promote weight loss and the DPP4s are weight neutral. Again, this will give us a robust advantage whenever there is a weight reduction. Many other parameters will come down. Now, what are the benefits of this combination? Targeting multiple pathophysiological pathways, as I showed you, the Omnis octet, most of it is covered when you combine with this. And if there is a metformin in the background, it works wonderfully well. It is safer, rapid, and produces sustained glycemic control, improves both insulin resistance and beta cell function, as we saw the evidence. It helps to reduce weight and, of course, to some extent blood pressure, but it is not indicated as an antihypertensive. About 5 to 6 mm of systolic blood pressure reduction is seen, which is a part of these pleiotropic benefits. It reduces the pill burden, and definitely in Indian context, it is cost effective. Thank you very much for patient hearing.
Thank you, Dr. Murthy. Excellent talk and well in time. You finished well in time. Thank you very much. And I think now it's time for, without delay, time for the next talk. And that talk will be on new antibiotics. As I said earlier, in India, antibiotics abuse is a big problem. And because of that, we have developed resistance to almost all known antibiotics. I will like to say only one line, that out of 10 persons whom antibiotics is given, only 1 person requires it. So we are very eager to listen about this new antibiotic. Dr. Rahul Sharma will be talking about it. So I think his introductory slide. Dr. Rahul Sharma is a MBBS MD medicine, DNB medicine, DM pulmonary medicine, critical care and sleep medicine. He's a gold medalist and he is fellow of so many organizations, including sleep medicine, very exciting branch, and additional director of Department of Pulmonary Critical Care, Fortis Hospital, Noida. Trained in advanced bronchoscopy and pleuroscopy at Academia Singapore General Hospital in July 2018. He's an academic membership in member of American Thoracic Society, ATS, life member of National College of Chest Physician, NCCP, life member of Association of Physicians of India, API, life member of Indian Society of Critical Care Medicine, and many more in his efforts. He has 10 solid years of practice experience, presented 2 original research papers, a oral and 1 poster presentation in 19th Congress of Asian Pacific Society of Respirology, and conducted research on assessment of craniofacial and upper airway profile in pediatric patients with sleep disorder, breathing, and association of serum albumin and bilirubin at admission with severity of acute ischemic stroke and functional outcome, and provided guidance to DNB students. His special interest in obstructive airway diseases, severe asthma management, interventional pulmonology, and interstitial lung disease, biologicals and respiratory disease, sleep medicine, and polysomnography, intensive care medicine, ARDS management, home ventilators, and so on. So without much delay, I invite Dr. Rahul Kumar Sharma to talk about this new antibiotic.
Thank you very much for this kind words, and I'm very glad to be on this platform. Good evening, everyone. So I'll be talking about the new antibiotics, and probably, as you said, that antibiotics are misused in country. That's why we need some kind of new antibiotics. But again, we need to be very, very careful that they should not be misused. So I'll share my slide regarding this new antibiotics. I hope my slides are visible now.
Not yet, sir.
So I'll be talking about
Dr. Sharma, you're muted.
I think there is some network issue.
my slides
at
are
the
visible now.
thing.
My
No, sir,
slides-
not yet. Not yet, sir, not yet. So you can put off your video. I think that will increase the bandwidth. Yeah. Now it is visible.
It is visible. So we're talking about antibiotics.
Sir, your voice is not properly audible. You can put off your video.
I have some in terms of the it is relatively new antibiotics, but it's still available. Implementation is being taken from R&D team of WOCAD. So as we know that MRSA infection is rising, we talk about gram-negative infection as far as the overall versus combined gram-negative infection, which include E. coli, Acinetobacter, and Klebsiella. And this is the scenario worldwide, USA, Europe, Latin America, everywhere. This is the scenario that we are seeing. And the rates has also been increased in India. This is the ICMR data, which is showing that the rate of MRSA in India has been increased from 28 to 42%. Even nowadays, because of the increased lifespan and more and more new advances in the management of the patient, we see most of the critical patient which has diabetes that we were talking about a few molecules, chronic kidney disease, liver disease, heart disease. So we need to be very, very careful when we are giving these antibiotics in terms of side effects, effect on other organs and drug-drug interactions. I don't know why these pictures are not coming, but the mortality is very, very high when we talk about MRSA-related bloodstream infection, endocarditis, and pneumonia. Even the infection is very, very difficult when it comes to joints, prosthesis, diabetic foot infection, and necrotizing fasciitis. So there are high chances of failure and morbidity there. That is why we need some kind of antibiotic which has good distribution and penetration. So when we talk about MRSA treatment, we talk about few antibiotics which is already in the market in terms of teicoplanin, vancomycin, clindamycin, linezolid, tigecycline, and daptomycin. But one thing which is very, very common in these antibiotics is that most of these antibiotics are either bacteriostatic or slow bactericidal, and they have their side effects in terms of liver and renal functions, peripheral and optic neuropathies. They are not very, very active as far as the lung infections are concerned. And the most common antibiotics that we often use in our OPD, especially the surgical patient, linezolid and tigecycline, they are bacteriostatic antibiotics. So this is again a very, very important concern whenever we are using antibiotics, again, gram-positive infection. Oral form, linezolid and clindamycin, which are readily available, but they are bacteriostatic and they have high chances of resistance. Especially diarrhea and Clostridium difficile colitis is very, very common when you give these antibiotics for a longer period of time. And, developing a new antibiotic is a Herculean task. It is not as simple as developing, some new molecules on which the research is going on. Antibiotics, you need to have multiple level of studies and phase 1, phase 2, phase 3. So this is very, very important. When a new antibiotics comes into the market, we should use it very, very judiciously. Levonadifloxacin is that molecule that we are talking about here. It is one of the kind of benzoquinoline structure which impart unique mode of action and broader coverage with excellent safety. Broad spectrum against all kind of gram-positive infection, whether it is VRSA, MRSA, VISA, or you have quinoline-sensitive gram-negative infection, and even it is very, very effective against atypical and anaerobic bacteria. It has rapid bactericidal activity, even against slow-growing Staphylococcus and presence of high bacterial load. Excellent biofilm and immunomodulatory effect, which is an add-on advantage. The pharmacokinetics is very, very good. Even the oral molecules are readily available in more than 90% of the bioavailability, and there is no loading dose required, and the dose adjustment is not required when the patient has compromised other organ function. Cardiac safe static enzyme elevation, all of these things has not been seen. So the safety is very, very robust, and even if you use it for a longer period of time, resistance has not so far reported from any part of the India. So faster oral and IV antibiotics, and it has been utilized in more than 45,000 patients with the good research available, Indian as well as from abroad. It is available in two forms. IV form is called levonadifloxacin, and oral form is a prodrug which is called L20. The different doses, the frequency is twice a day. Days of therapy depending on the infection and the site of infection can be used in hospital, and patient can be switched to the oral therapy and can be discharged easily on the oral antibiotics. When you talk about oral versus IV levonadifloxacin, pharmacokinetic profiles is almost similar whenever you are giving IV or oral. Absorption is very, very good, 90% bioavailability, even if you are giving it in oral form, and it does not alter with the food, whether you are giving fasting or postprandial. Distribution is mainly in the tissue and unbound plasma concentration. Metabolism is again hepatic phase 2 conjugative metabolism. So there is very, very minimal drug-drug interaction that has been seen, and excretion is not affected by either oral or your renal or liver parameters. So it has a broadest spectrum of coverage that you can think about, including your all kind of resistance gram-positive bugs that we often encountered in our ICU practice. So other unique features is that over a period of time, we have seen that patients who are in long-term ICU stays, they have this biofilm formation over, over the catheters, but most of the time, MROC has, or the levonadifloxacin has very, very good efficacy regarding this, and it can eradicate more than 90% of the bacteria, even if the biofilm is there embedded on catheters. I don't know why these pictures are not coming. It is high density killing, which is seen with this, and it has a favorable outcome even if there is a high bacterial load. Pharmacokinetics, pharmacodynamics we have already administered. So we have seen that even in the fluids as well as in the macro side, which is in the lung, the penetration is very, very good. So activity is enhanced by, so the immunomodulatory effect is one of such features which is very, very important. Immunomodulates and, given this molecule. Safety profile is again very, very good in this patient. There is no nephrotoxicity, hepatotoxicity, QTC prolonged interval, no thrombocytopenia, no CYP mediated drug-drug interaction, no seizure potential, and no phototoxicity. So practically no dose adjustment are required, even if your patient is in the sickest form with multi-organ dysfunction. It has approved indication for bacterial skin and skin structure infections, diabetic foot infections, concurrent bacterial infection, and have potential use where we can utilize it in the community-acquired pneumonia, bone and joint infections, febrile neutropenias, device-associated infection where the biofilm formation is very, very high, and catheter-related bloodstream infections. There are different studies which is published in India as well as outside. Pioneer study is one such study where they are looking into the monitoring of oral legonadifloxacin, and there was 7 chief investigator with 107 co-investigator at 92 sites across India with a data of more than 1,200 patients, and the efficacy is very, very good. Even if you see that there are abscesses, septicemia, pneumonia, secondary bacterial infection, febrile neutropenia, very good in these patients. Adverse events are very, very minimal, and it is limited to constipation, nausea, vomiting, fatigue, diarrhea, hypoglycemia, which is very, very, easily manageable symptoms. Other studies in joint and bone and joint infection as well as community-acquired bacterial pneumonia was a very good, significant safety profile as well as clinical cure rate with a mean duration of therapy in sickest patient can be given up to 26 days without any failure. Same goes for clinical cure as far as the community-acquired pneumonia is concerned, with overall therapy duration of 13 days, and the success rate is seen in more than 24% of the patients. This is the case that I have encountered. A very young chap presented to us with respiratory distress and an abscess on the hand, which he was correlated because he was having anemia and he was transfused with iron. So he was correlating it with the IV injection use, but he was admitted with fever for 4-5 days, and he was already given Targocid, Linocid, and Meropenem for 6 days. Blood culture shows GPC is positive and culture shows MRSA. Lung picture was showing, these infiltrates. So the patient was very, very sick and transferred to us. I don't know whether this video will work on or not. There was sternocleidoid, the back muscle abscess was there. So you can see there is a significant abscess there. And this is the muscle abscess. If you can just give some, the muscle abscesses are there. So there were multiple abscesses with cavitatory lung lesions, which you can see in this picture. There were multiple cavitatory opacities that was there. So the patient had FiO2, increased FiO2 with distress. PCT was positive. We did do the bronchoscopy to rule out other infection in terms of tuberculosis, fungal infection. All were negative. Patients, multiple report from multiple sides, whether it was the neck abscess, hand abscess, or lavage. It was showing that the patient is growing only Staphylococcus infection, which was resistant to most of the drug. It was persistent fever and dysphagia despite being on good antibiotic coverage in terms of meropenem. The patient was added linezolid later on, as well as vancomycin, but there was no response. So Mbroc was one of the options that we were considering at that particular time, but initially we had this reservation versus the reserve drug that no, this drug, because the all standard drugs are not working, where this drug will work or not. So the patient was added on vancomycin, but there was same response, and even the condition worsened further. Patient was intubated. You can see the clear increase in the abscess. So drainage was done by ENT people. Multiple muscle abscess that has increased. The cavity size of the lung has increased. Patient developed bilateral pleural effusion. And believe me, this goes till the prostate. So patient even had prostatic abscesses formation, which was again, everything was growing MRSA. Fever continued, patient was intubated. And we again asked whether we can do neck drainage or not. Everyone said yes in the ICU. MROC, everyone was reserved. So the patient ultimately was started on MROC or levonadifloxacin. Patient showed significant recovery after 48 hours. Of course, the drainage of the neck part was done, but other abscesses could not be drained that time. Oxygen requirement improved, extubated on third day of MROC therapy and off oxygen for 5 days. Dysphagia improving. Still, there was a long way to go, and we were still contemplating whether it is because of the drug or there is some other reason. Later on, all the drugs were removed except this MROC, and we were giving, all kind of supportive nutritional therapies, physiotherapies to this patient. Patient remarkably improved, and this was the X-ray which was last taken. And this patient has visited me 3 days back in my ICU. Levonadifloxacin is a new standard of care for resistance gram-positive infection, because of its potent MICs, again bio intracellular oral assessment are required. Was Jipman, and it is again results.
I think Dr. Rahul not audible.
Yeah, he's not audible at all.
Yeah.
I think he's in hospital and he landed.
There's some network issue.
So what to do?
I'm not in hospital. I'm at my house, but I don't know why this network issues are there. So I think the last slide is. This is probably the last slide. I don't know why this network just has been so difficult. So MROC is one of the solutions that we can always look into when we are talking about standard of care, because it has good bioavailability, good broad spectrum coverage, no dose adjustment are required, and susceptibility is again very, very good. But there is a long way to go, and we need more and more data regarding this. So I'll just stop here. Thank you very much for your patient listening, and I'm really sorry for this unstable network. I don't know why it is happening. Thank you very much.
Thank you, Dr. Rahul. Despite of all these problems, you were able to deliver what you wanted to talk. Thank you very much for your all adjustments. So I think now the time is for the questions, and I have received a lot of questions. So these questions had to be taken. For any CME, the most important part is the question and answer session, because every doctor knows everything. The only thing required is a good discussion. So the questions are here, which I can find out. First question is that first question is regarding the titration of the insulin, especially the basal one. How one should go for the titration of the basal insulin? So this question, of course, will be taken by Dr. Sanket. I think he's not here. I don't see. So I think this question can also be taken by Professor Murthy.
Yes, sir.
Yeah, you can take this question.
Yeah, I think the basal insulin, the titration would be based on the fasting value. So you would normally advise patients to get the FPS, and we usually train them to have a glucometer and adjust themselves. Simple algorithm can be given in view of their age, considering other comorbidities like a renal function, and it to be slow in up titration. Otherwise, weekly up titration is what we practice. And it's very easy to prime, because especially if in a drug naive, that is insulin naive patients, if you're initiating, you need to be careful because of the phobia patients have. You need to train the relatives. You can, in fact, train the diabetes educators or a nurse who's working with you to take care of their, after 2 days or 3 days, call them. Because recently, to share experience, sir, we had a patient, youngster, where about 35, 40, type 2, initiated an insulin, and he presented with 400, 500 sugars. And after 3 days, I told him, you get back with your readings on the phone. He called me and says, reading is again 400, 500. Then I said, okay, you increased by 4 units, because I was a little apprehensive, because I had put him on a basal bolus regimen. And after 3 days, again, he calls and says 400, 500 reading. Then I said, no, you come down, you bring the pen, you bring the glucometer. I knew something is wrong. And this patient was taught, unfortunately, by the nurse, where he went to the nearby nursing home, that he turned to that units, 24 units, and keeping on his thigh, and after 10 seconds, he's removing without even injecting it. So the insulin 300 IU is like that for 6 days, unfortunately. I mean, this is where you need to train our patients, and that phobia we need to come over.
Very good answers. And I think one more trick which we do usually, that every third day we ask them to increase 2 units till we go to 130 fasting. And when
110, depending on the patient.
Yeah, depending upon the patients. Of course, different type of patients require different type of insulin doses. As you mentioned, one patient I remember, he was a pulmonary tuberculosis patient, bilateral pulmonary tuberculosis. He was just weighing 28 kg. And when I started only 10 units BD, my resident said, sir, his blood sugar is 800. You are starting 20 units only. I said, just watch for after 10 days, 7 days, because he was from a remote village. I can't afford hypoglycemia. After 10 days, when he came, he was perfectly all right, even with 10 units, because he was having tuberculosis. He was having hypoglycemia from last so many days, and he was having the concentrated glucose, and his weight was only 20 kg. So the patient is still receiving insulin. His pulmonary tuberculosis has gone, and now he has gained weight. He's 50 kg. Still, he's on insulin because he now loves insulin. So it is just only starting insulin the right patient. They will love it. Next question is to you only. That is which is the best gliptin out of this Bilda, Sita, Lina, Tina, and so many others? Which is the best one to you?
I think it's a difficult question, sir, to answer, but I would take Sita, which is one of the longest existing molecule in the market, and it is like time tested, like metformin. Metformin, hardly we have evidence of CVOT, all that, but we continue to do it. But Sita would be the preference because of OD preparation, CV neutral, and CVOT trial, which is there, and it is a long studied molecule. Of course, linagliptin with Camelina and Carolina both have shown good robust evidence, but that somehow unfortunately got a niche into only patients renal. Then you have Lina, otherwise no Lina. I mean, unfortunately a good molecule, but it got narrowed down indication because of its renal indication, unfortunately. Bilda is a twice a day. That's something which makes it, the compliance part, what we're talking about, the retention, patients' consistency in taking the pills, all that is not taken care. And hence I would prefer Sita over others in routine clinical practice. I
agree to you, because sitagliptin has a robust data, which other gliptins may not have at this moment. So I agree to you. I will also prefer sitagliptin. That is the gold molecule at present in gliptin arena. So next question is, what additional benefits have you observed in clinical experience with sitagliptin plus?
I didn't understand. Sitagliptin additional benefit. Sorry, sir?
Yeah, he's saying sitagliptin plus. I think he is talking about combination of gliptin and SGLT2 inhibitors.
Yeah, I think that was a topic of discussion today, where the combination FDC will give you all the pleiotropic benefits. It literally counters 5 out of 8 omnious octet. That itself, you're trying to correct the basic pathophysiological defect in the diabetic disease. And of course, the pleiotropic benefits with respect to the weight loss, which is clearly seen. And there are evidences now for NASH, safe in the elderly, reduction in the NASH component with the gliptins and SGLT2. That is where you give the pleiotropic benefits when you combine along with metformin. In fact, weight loss itself will counter many disadvantages what a patient might come with, including OSA. There are evidences now coming with obstructive sleep apnea for weight loss, the BP reduction. These are the things which n number of things we can enumerate. The CKD patients also, there is heart failure reduction in the hospitalization for heart failure, and of course CV mortality. These are the evidences we have. And above all, when you talk about the Indian perspective, the cost benefit which you have with this combination.
Here, I will like to ask one question from my side.
Sir.
Usually, my teaching initially was that gliptins are for masses, SGLT2 inhibitors are for classes. So, whether you like to prescribe SGLT2 inhibitors also to everybody or only to those patients who have high risk cardiovascular renal disease. That is my question.
Your statement was absolutely right about 3 years back, but today it is for the masses. It is literally for every diabetes. That's what I said during my talk also. It will sound that as if it's a criminal offense if you don't initiate anybody SGLT2, because that primary prevention concept is taking the front seat now, where I showed you one of the evidences. The guidelines have been showing that patients above 55 years, patients with the risk factors, can be initiated for a primary prevention. So
I agree to you. And I also do the same thing. Just I raise this question to make things more clear.
Yes.
I agree to you. Today, it is for masses. All the 3 drugs, metformin, gliptin, and SGLT2 inhibitors. At least 3 drugs must be given to everybody.
True, sir.
Now, my next question is to Dr. Dr. Snehal. He has come. Dr. Snehal, this question belongs to my area, that is chronobiology or chronomedicine, management of the glycemic variability with insulin analog. Insulin and glycemic variability, the topic which belongs to my specialty, chronomedicine.
So yeah, there is a lot of insight. There are a lot of insights, and there is a lot of interest in this glycemic variability, which appears to be the 4th parameter that we need to check in our patients apart from your fasting, postprandial, HbA1c. It has been proved time and again that glycemic variability improvement of glycemic variability do improve the outcomes in terms of mostly microvascular but also macrovascular complications. To tackle that, yes, need of use of insulin analogs are useful. But again, sir, it is quite individualized, where the PK/PDs of different insulins in terms of their peaks and their duration of action, we need to kind of juggle between these time ranges that each insulin, whether it be human insulin or analog, they provide, and then try to achieve as normal or as physiologic insulin variations, basal as well as the boluses that we tend to see in most of the non-diabetic patient as well. Saying that, analogs has helped to reduce hypoglycemia and cover the postprandial peaks, the ultra fast acting and the fast acting, rapid acting insulin analogs. But even human insulins, the regular human insulins also do play a good role in many subset of our patients.
That is correct. The glycemic variability will be best managed by the basal bolus therapy. And of course, analogs will help because they will help in the same way, less needle pricks, and will have the almost same results. And you are very correct that very long-acting insulin like the Gludac combining with the ultra short-acting insulin, that can also be a very good alternative to reduce glycemic variability. Not only the prandial one, also the long-acting fasting will also be corrected. Another question to you, sir, again, is the management of hyperglycemic diabetic ketosis.
Hyperglycemic diabetic coma, I mean, HHA.
Very long question. Just to summarize 2 lines. It's very.
So it's a differential diagnosis for type 2 diabetic patients who are insulinopenic, coming with very high glucose levels in cases of diabetic versus diabetic ketoacidosis. The underlying problem is in dehydration and insulin lack, and the management more or less it revolves around correction of hydration and correction of severe hypoglycemia that is seen in HHN as compared to the decay by IV insulin. So more or less the base of management is almost same in both the cases. Some just extra efforts need to be put in terms of an HHS to first of all find out the cause of the same and prevent further dehydration. At the same time, not overdo with the hydration, especially in elderly patients.
Thank you, sir, for answering this difficult question in a very simple way. My next question will be to that is regarding the antibiotic. I think doctor is not here. He is not here. So who will take this question? Place of therapy of levonorexifloxacin for diabetic foot infections. Anybody can take this question? Or I will take in the last. Next question I will ask to Professor Murthy again. And that question is regarding the experience of genitourinary infection with a combining SGLT2 inhibitor plus DP4 inhibitors. Dr. Murthy, are you here? This question is definitely asked in most of the conferences, most of the meeting, that when you combine SGLT2 inhibitors with gliptins, the genitourinary infection goes down. You agree to it?
Definitely, sir. I agree. And I showed a slide also that the evidence, the meta-analysis of 3 studies, including DiFranzo and Rosenstock, which clearly demonstrated the incidence of GTIs comes down when you combine DPP4s. And the proposed mechanism of action is that the DPP4 enzymes in the bacteria are inhibited and thus the infection rates comes down. And that's one of the rationales we always advise, go with this combination, which is one of the troublesome side effects, adverse events of SGLT2 as a class is the GTIs and UTIs. So that's something where can be countered by rationally combining these 2 drugs.
And another question again to you is, which SGLT2 inhibitor is preferred elderly type 2 diabetes with severe osteopenia? In osteopenia, which SGLT2 inhibitor you will prefer and why?
I think DAPA and EMPA both have got evidence now. CANA, of course, we don't in fractures. But EMPA, there is a study in the elderly population where the inclusion criteria was above 80 years. The inclusion criteria, elderly. This is one of the few trials which is included this high risk or fragile patients. So those 2 are safe. So when it comes to the evidence, it's EMPA first and then DAPA. When it comes to the elderly with osteopenia.
Good, sir. Very good answer to that. And I think also we should consider the osteocalcin levels. That will decide better that whether it will be induced by the drug or not. Another question is, which gliptin would you preferable in patient with chronic hepatitis B with raised AST, ALT having type 2 diabetes?
Okay. I think Vilda is something which in this group, because of the excretion, you can choose. And the linagliptin is something which you should not. Okay, that is something which you can think about.
Gliptins are not the good drug when the liver is compromised.
No, but somebody wants that answer. So
agree to you.
Exactly. There are better options available.
Yeah.
If at all you want to go, I think these are the 2 things which you can think of.
So one question was not answered. If anybody can take that regarding the experience of this place of therapy for levonorexifloxacin and diabetic foot and the also in tuberculosis. That remained unanswered.
I think
it seems Dr. Rahul dropped off because of network issue.
No problem. So from your side, Walker side, if Dr. Alpa or anybody can take this question, because I'm not very sure this molecule is new for me, and I cannot answer until I'm very sure.
I think tuberculosis, Dr. Rahul did not show any evidence, sir.
Tuberculosis, we
Evidence
must
in
not
diabetic
use
food.
any fluoxetine.
Yeah.
In first line, this is hazardous again, and this is called cause of the MDR. We are raising more MDR tuberculosis just by using the fluoxetine left and right. So I said in the beginning that antibiotics should be used with very, very caution. And I will ask the WOCAD people, do not promote it till the last end, so that there may be some antibiotics safe for those who require them. Not everybody is taking the antibiotics. So I think we had covered most of the questions. One last question is, what are the current cutoff EGFR values for limiting use of SGLT2 inhibitors? By that value, you will not use SGLT2 inhibitors.
I think below 30, we should not. Guidelines say 45, but in the West, it is reduced already to 30. In India also, it will come down. One of the molecules, that is DAPA, has got reduction to 30. But below 30, most of that is CKD stage 3. None of us use any molecules. Mostly we go on to the insulins. So in general, in routine clinical practice, but the gliptins are studied up to 15 ml. The GLP-1s are studied up to 15 ml. That is people who are on dialysis also. It has gone to that extent. Yes, even in non-diabetics, it has been studied. But as of today, you just keep it as 45 ml. You don't initiate. Up to 30 ml, you can continue. If somebody is there already on the SGLT2, even if there is a drop till 30, you can still continue. Below 30, you need to discontinue.
The question regarding GLP-1 receptor, I think, has no meaning because it is already being used for weight reduction. There is no doubt about it. So that was the last question. I think it is already 9:20. So if everybody agrees, we should call it a day. Over to Dr. Alpa.
Thank you, sir. Thank you, Dr. N.S. Verma, to take this wonderful chair, this session for today's webinar. And also I extend my gratitude to all the speakers to profoundly and crisply answer all the questions and do the discussions. And I would like to hand over to Mr. Candy. He is our National Sales Manager for Metabolics Division, to give the vote of thanks.
Thank you, Dr. Alpa. Good evening once again to all of you. As Dr. Sanket started his opening remarks with welcome for the scientific feast. Absolutely, this is a scientific feast. We started with sulfonylureas moving to insulins, and then DPP4 and SGLT2 combinations, and then a newer molecule which is being developed by WOCAD. So absolutely a scientific feast for this weekend. And I would like to thank the chairperson, Dr. N.S. Verma, for beautifully sharing and introducing the speakers. And I would like to thank Dr. Snegal Tana, who has started and given his insight about sulfonylureas as well as insulins. And as we are celebrating 100 years of insulins, as WOCADians, we are very proud to say that we are celebrating Osulin 20 years, as well as our Glimade 20 years. The first Indian human insulin, as well as we do have, biosimilar, first biosimilar of Glarigen in the Indian maker. Followed by, I would like to thank Dr. Srinivasa Murthy, sir, as usual. So given a very good insight of our Sitagliptin, that is sitagliptin with DAPA combinations, where to use, where not to use. And I would like to thank Dr. Rahul Sharma for highlighting our new molecule MROC to the medical fraternity. And also I would like to thank 1,134 live delegates for attending and enjoying the benefit of this scientific feast. And thank you, Dr. Sanket and Alpha, for the medical team. And I would like to thank our Vice President, Mr. Vishnu, Priyanka from marketing team, for organizing such a wonderful program to engage and give a scientific feast to the medical fraternity. And I would like to thank all my team for organizing such a massive 1,134 doctors in the Saturday evening to attend the session lively. So thank you very much and wish you all a happy weekend. Good night to all of you.
Good night. Good night.
Thank you, sir. Thank you, everyone.
Thank
Thank
you.
you so much.
Thank you so much,
for
sir.
being here.
Good night. Good night. Good night, Srinivasa Murthy, sir.
Good night, Vishnu. Good night.
Thank you, sir.
Good catch up.
Thank you so much.
Yeah. Thank you, everyone. Bye.
Okay, good night.